We start.
Let's see. Okay.
Yeah, start this morning's EGM Conference. This is our first session.
10:28. First name should be CHUN.
We start first. Traditionally Q.
In this EKG, we can see the and also we can see
CHUN.
QS and ST elevation in
123
and consistent with the end receptor MR, and also in the rhythm trip, tachycardia ongoing, and we can see so many morphologies of QRS. I don't know homopology.
Homopologies. In the rhythm strip. Okay. Yes. Good. Good. And who's next?
Left back investigation, and also I'm a very part in pathology QRS and this elevation. Last QRS P value not clearly see.
What did you see? What did you see?
P
PVC? PV?
P wave.
P wave. I see.
Clearly see.
So later part shows a P current quantum relationship, right?
Yeah. Right.
But the one bit before the end, there's some different morphology as Q pointed out. Okay, Josiah.
I agree with that. The regular heart rate is regular. Heart rate is 150 to 160, and different course morphologies. Also, so you can see the B1 is a PR Chinese conductor to P wave.
So how's the rhythm status of the first half and the later half?
First half looks like white for tachycardia,
Mhm.
and then it's be the some fusion bit,
Rhythm bit.
and then maybe it actually this one.
One.
Because when you see the Q,
Oh.
it can be
So later half part shows a PQRS quantum relationship. So then what do take the first wide curse with it? Is it ventricular rhythm, aberrancy, excitation, paced rhythm? What is your differential diagnosis?
you say it's one-to-one conduction, it can be the respective deferency.
How's the rate? Wide curse rhythm versus narrow curse rhythm? Not narrow, but I think it shows a significant ST elevation.
Yes.
It's making confusion, right? Rate? Almost same? Almost same. Then why the first part shows wide curse, later part shows narrow curse? Copy?
So I think the first part is a VT because we see the same morphology in 2, 3, and AVF, and they're all negative, suggesting that the vector is moving from down upward, from vertical upward. And then in the rhythm strip, we see these bumps here. There's one here, there's one here. think another here.
Okay,
This
okay,
is-
you use this laser point.
So there's one there.
Mm,
I think there's one here. Another here. There. There. And here. Here. So I think there's an element of AV dissociation as well, together with this broad complex tachycardia. Intrinsic deflection looks a bit prolonged, not so great, but I think it's a little prolonged. So in the context of the ST elevation in V1 to V3, which suggests an MI, I would think that the first half of the ECG is a VT post MI. Then getting to the middle, I think I see consistent P waves before the QRS. So this is a P QRS, P QRS, P, but this QRS looks a bit different. P, this also looks a bit different. So I think around here we have some fusion, but I can't explain why this last one, these two are different from these previous two. I think these ones are fusion beats, but this and this, I can't explain why they are different. Then here, I think we have maybe a sinus capture.
okay. And you presented this case, right? But some of people remember this patient, but the different ECG, right? Yeah. Ah, that's why Georgia was so nervous.
Yes.
So I agree with the first. We can intrinsicalism. But some notes that suspicious and PhD and either different personal there is a EGM. I think this is a particular reading with about one responsibility. Later. So almost the same weight, and there is a one-to-one relationship between characters. And there's a various character morphology. But with the character morphology kept changing. So yeah, I present this case, so I know about the patient, but thinking about that, the terrace elevation, conduction system has been very injured, so this keep changing QRS morphology suggests that the front rather of a conduction block on 0.4 up in a scale. Rather of block change.
Sugi, do you have any further comment? Don't escape. Try it.
Yeah, but the patient. This is a 39 years.
No, 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 no,
Oh,
no. Don't show the answer. Because the wide curve rhythm and the narrow curve rhythm shows a similar rate, even though it is the ventricular rhythm of ET, it's hard to differentiate AV dissociation because rate is very similar, right? And the later part shows the PQRST shows the almost one-tone conduction, but still there's changing QRS morphology. So, Dr. Huang, can you hear me?
I can hear you.
This patient actually the malignant melanoma patient. Am I right?
fine.
Thymoma.
Okay.
And the oncologist used the immune checkpoint inhibitor,
Mhm.
and afterward he has severe autoimmune reaction, and
I see.
his ECG
Yeah.
changed abruptly.
So if you, I think it copy really well ECG there. So if you look at the lead one, there's a P wave, PR interval vary, certainly. As you said, it's almost isorhythmic dissociation. So that's ventricular rhythm with the acute to ischemic change precordially V1, V2, V3 suggests that he may have an acute event, whether coronary embolism or something going on, but suggests certainly. However, in the lead 2, as you can see, bottom 2 rhythm strip, take a look at it. There's this impression that the intermittent QRS width variation, I think that's still not a purely VT, probably some degree of fusion going on. You can further prove that, and when the wide complex stop becoming narrowish looking, there's a different degree of fusion going on until that negative QRS complex. And then last 7-bit, if you look at it, the R wave becomes suddenly upright. That's how his native QRS complex sinus rhythm. And then second last bit is also fusion. That one, yeah. So I think this patient had probably slow VT. Question of whether mechanism is re-entry of focal VT is difficult to say because the rate is very stable. But then looks like origin of VT most likely left ventricle posterior region or inferior posterior is a Q23 AVF. So I don't know whether this patient had also significant impact on the both anterior coronary and posterior wall territory is unknown, but certainly dominant is in anterior wall. Now, V1, unusually patient has a deep Q wave. Can you see that? Even though patient had MI, right? What did that mean? This patient probably had a posterior infarct as well, looks like. So I think this is, that's why you have normally you don't see deep RS wave in the V1 during the acute anterior MI. You should see a segment elevation, but then Q and a segment elevation. So I think probably affecting both territory, right and left coronary artery system. Okay, that's I think we can get here. So bottom line, slow VT with the possible ischemic event involving global picture, most likely, and then has some intermittent fusion between VT and then native sinus rhythm. That's what it is. Any
Initially, this picture shows myopericarditis as the adverse effects of immune checkpoint inhibitor.
Yeah, probably.
Physician underwent the coronary angiogram was normal.
Yeah,
but
so it's probably global event.
Even elevate higher, right? So afterward, did they check the echo follow?
Yeah, they had. But the echo was still with the decreased ejection fraction around 28, and also region 1 motion was still there. So,
Okay, and here, so please comment. All of a sudden. All the cardiology the situation happens all of a sudden. I don't know. Underline. Maybe MI. Because the ST elevation and the precordial leads. Although it is wide, I think it is in sinus rhythm, so it is not VT, just sinus tachycardia with
segment elevated all the way up to the B4.
ST elevation throughout and
Not just on the anterior, probably all the way going down.
Okay, so do you have any comment? Account number 2. Is number 2. I just agreed all of the previous comments. And so what do you think the reason for that elevation in this patient? Coronary angio was normal. So was there the further coronary attack during follow, or initially the S elevation was shown in old leads, right? Do you have the previous ECG? Yeah,
Yes.
let's review.
Yeah, lower myocarditis, acute circulatory event.
This was the very first one before the CT, and after 2 hours later, it changed to like this. But prior to this ECG, I don't have.
This is CCU patient.
Yeah,
Check for.
yeah.
No, this patient. Yeah, I forgot.
Is Dr. Bob, can you
Yes,
hear me?
yes.
Is it possible that the patient had acute reaction to developing acute myocarditis?
Yeah, I
My-
think so.
Yeah, acute myocarditis, microcirculatory ischemia. I think that looks like what's going on here. Okay, yeah, troponin is elevated, all that is consistent with it. So I think, you know, and again, when you look at the acute enteroma, you have a deep S wave of V1, you need to watch carefully, make sure that is not a, you know, global or either two territory ischemia. Sometimes we miss the diagnosis. So
Please let us know the history and the course of this crypto patient.
Okay, this patient was female with 39 years old, and her chief complaint was DOE and insomnia, which occurred 3 days ago. This patient was diagnosed with dyma in 3 years ago, and operation and radiation therapy was administered, and after that metastasis was confirmed, so they did 6 cycles of chemotherapy, and NAD was accomplished in 2023. But last year, for right towards setting metastasis was found, and the immune checkpoint inhibitor, the pembrolizumab, was initiated 2 weeks prior to the patient presentation, and 3 days prior to the patient presentation, he experienced the DOE. And without, other than dyma, she has no other medical records. And then this was the chest X-ray on the ER. This was the first ECG when she was ER. The laboratory test was like this. As you can see, the cardiac marker was elevated, but the CK was more elevated compared to other parameters, and also LFT was elevated. So firstly, she was admitted to oncology on the diagnosis of immune-related myositis. So, and for the records, and this was her TT prior to this event. The ejection fraction was normal, and after hospitalization, still ejection fraction was normal, even though the chamber was a little bit decreased. So under the myositis diagnosis, they used the straight steroid course therapy and immunoglobulin therapy was started. But after that, cardiac markers even elevated more, but the CK decreased. And that day, the TT was like this. The ejection fraction was about 20%. And then, as you can see, there was newly developed regional motion at the antero to anteroceptor area. And this was the first ECG. And after 2 hours, it changed to like this.
I got a question for you. Is this patient had a myalgia, global myalgia?
Yeah, and then she complained whole body ache.
Okay, so because of this patient clinical feature, as you know, heart has 1/3 of heart muscle is a skeletal muscle. So probably had a more reaction to the skeletal motion part of a muscle, the cardiac muscle. That's why your generalized global myositis involving cardiac. That may explain why your ejection fraction is relatively preserved. Okay.
This is VT.
ET, yes.
And in the previous ECG, the first ECG, I don't know why this patient shows significant S elevation only the right precordial and septal area. Other areas it's okay. So is there any report the ICI the related myocarditis as preferred
That is that
myocardial reason? No,
yeah,
like Do you have any idea, Dr. Wang?
I think, because of, if you look at the carefully, S-segment elevation also in the leader 2 and 3 in AVF, except that because of predominant QS wave there. I think probably because of, precordial lead being close to precordial chest unipolar. I think that's what manifests the way it is. So maybe it has to do with the lead, unipolar lead nature of the precordial leads that shows more accentuated. Because you can look at it, V4 even has a segment elevation. Yeah, there is a segment elevation there too. So I think it's just global myocarditis, more pronounced the seen because of unipolar recording of precordial. I think that's what it is. And then also I haven't seen this deep Q wave in the V1 so a long time. It's very unusual. Okay.
Still, I have a curiosity why the later part of a narrow QRS rhythm change after single PVC. Is it related to the underbranch block or?
No. I think if you look at the, when the wide complex terminate, there's a gradual different degree of fusion going on back and forward between sinus and the PT. So you can see.
Usually all those are the fusion beats.
Yeah, they're all fusion beat. And you only become normal sinus rhythm last, let's say 5 beat from 7 beat, 7, 8, 9, 10 become normal beat. Okay, those all fusion. Because you get the PR interval, they change it slightly. And then very last second one is also fusion. You see PR is got shorter. The negative, yeah, that guy. PR is shorter than other. See? So that's
fusion beats looks even narrow than the sinus conducted QRS.
right. That because of your BT looks like coming from the conduction system somewhere. Looks like very narrow. Probably that's the reason.
Balance the underbranch block, the hitting the ventricular rhythm and the partial underbranch block hit together and generating the narrow QRS and sinus conduct QRS. That's interesting. And the single PVC at this one, single PVC change, it is due to terminated BT and pure conducted QRS or some kind of a peeling back phenomenon.
I think it's a peeling back because your PR is shorter there. You see that PVC fusion bit there. So I think that's most likely peel back phenomenon. Refractory got shorter, so that's like a conducting normally again.
Dr. Tian Wang, could you please summarize peeling back briefly for fellows?
So who wants to summarize it? Second. So I think we discussed all. Do we need to summarize again? I don't think so.
No, I mean the peeling back phenomenon. Explain.
Yeah, peeling back phenomena is there's a 7 different mechanisms.
No, not you. I'm asking the Tian Huang.
Oh, I see. Second one. A junior Huang next time you call.
Okay, junior Huang is better.
I hope Professor Chen Huang summarized that. Peeling back phenomena, as you can see, even though there is some wide QRS, but there is some pre-extrasystal, and the refractory period got reset, then conducted to the narrow QRS. So peeling back.
Kyo, do you understand what this means? Oh, you understand? Okay. So, yeah. Any other comments? No. Okay. During the wide QRS rhythm, whether the reason it is the partial refractory period, the functional underbranch block or ventricular rhythm, just single PBs reset the refractory period, and it changed to be narrow QRS because the refractory period made the partial underbranch block reset. Okay, So after PVC, if there is some change of conduction abnormality, you should think about the mechanism. Okay. So I think do you have any other slides to present?
And, this is the last decision. After coronary angiography, they started amiodarone. They changed it like this. And like 3 days ago, she underwent cardiac biopsy to confirm that immune checkpoint inhibited myocarditis. And she's still in the hospital and treatment.
Get better?
Actually, the ejection fraction is still she's trying to extubate and we'll see.
So Simoma is vulnerable to any kind of autoimmune disease. So immune checkpoint inhibitor is
It's not going to go down.
should be very carefully used in this kind of patient. But her Simoma is registered to the radiation therapy, chemotherapy. So probably oncologist use it as the last line of therapy. So as a cardiologist, so what is the future plan? Definitely transplantation is not indicated, right?
Yeah, because
Cancer.
So what is your
She-
concern after pan-myocarditis? What do you worry? Do you see no acute change ejection fraction, but you got global myocarditis picture going on? When do you plan to repeat the echo? That's first question.
Repeat what? Repeat
Echocardiogram. Do you expect that this patient could stay normal ejection fraction? I don't think so. It's going to progress. So you need to monitor ejection fraction in this patient, cardiac function, okay? Because a patient already have a wider QRS complex, even though sinus rhythm, and you got right bundle branch block pattern, so conduction system involved. So I think you need to surveillance carefully. Next question is that do we start heart failure prophylactic therapy, ACE inhibitor, anything like those kind of picture? So you don't need.
They already did.
They already did? That's good news. Okay. So you do need to make sure that follow up this patient carefully. Patient may develop sudden death also. Okay. Risk of sudden death is pretty high, this type of patient.
Okay, so this is time to start the international EGM conference. Thank you very much, Dr. Shin.
Thank you, everyone. That's a wonderful case. Great.
Kim, Dr. Taehoon Kim's role. Okay.
Kim Johnson, and welcome to the conference.
Good morning, colleagues.
Morning.
I'm Daeon Kim from Yonsei University, and it is my great pleasure to welcome you to this monthly International EP Case Conference. And thank you to Dr. Taehoon Kim, who is leaving to USA to be a visiting scholar for 1 year. And today we have Dr. Kenneth Koo, Kai Leong from Malaysia, presenting with Dr. Karel Ma from Mongolia as our panelist. Dr. Koo, could you please begin?
Hey, good morning.
Morning.
So I'll just share my slides now.
Okay.
이거를 풀어줘야 돼.
Right, before I start my presentation, can everyone see my slides? The first page? Yeah, so a very good morning to everyone. My name is Kenneth Koo. I'm a cardiology fellow from the Sarawak Heart Center from Malaysia. So I'd like to thank the opportunity for me to share my case with everyone here. So let's get right into it. So this is the story of my patient. He is a 28-year-old man who presented with palpitations. And from the referral letter, we know that he got to be admitted into a private hospital a few months ago and was treated for SVT. That SVT was successfully terminated with adenosine, and the echo was essentially normal without any structural abnormalities. So this is the initial 12-lead ECG that demonstrates the SVT. Now, I'd like to just spend a couple of minutes describing this ECG. It is a broad, complex, regular tachycardia with what I would call a classical left blunder branch block morphology. There are no obvious sinus P waves seen in these 12 leads. However, we can see that there are inverted P waves seen over the inferior leads. By definition, this is still considered a short RP tachycardia, but the RP is not too short, as we can see the P wave still well out at the ST segments. Also, at the precordial leads V1, V2 to V3, we can see that there is a very thin, narrow, and slender R waves. So this generally means a septal activation of the tachycardia. So adenosine was given, and this is the post-adenosine conversion ECG to sinus rhythm. Now, of note, we can see that the left bundle branch block morphology has now disappeared. There are no delta waves, and the frontal plane axis remain the same. A side-by-side comparison. So with this information at hand, differential diagnosis includes an orthodromic AVRT or AVNRT with bundle branch block, bundle branch re-entry VT, or less likely AT with bundle branch block. So these are the differential diagnoses. So we brought the patient into our EP lab. We started off with a standard 3-wire diagnostic EP studies. From here, we can see that it is normal sinus rhythm. The AH and HV intervals are within normal range, and there is concentric atrial CS activation. We started our EP maneuvers by retrograde ventricular incremental pacing. And from here, we can see that there is eccentric atrial activation without signs of VA Wenckebach. So this finding tells us that there is a presence of an accessory pathway, likely on the left side, that is able to conduct retrogradely. We then continued to do antegrade atrial incremental pacing. And from here, we can see concentric atrial activation, and there is AV Wenckebach phenomenon. And then, while we are doing the antegrade atrial incremental pacing, we managed to induce a tachycardia. Now, it is a regular, broad, complex tachycardia with left bundle branch block morphology. From concentric atrial activation, it changed to eccentric atrial activation now during the tachycardia, and there is a 1-to-1 VA or AV relationship. We switch to the 12th lead during the tachycardia, and we can see that it has a left bundle branch block morphology, and essentially the same as the first surface 12th lead ECG that I've shown previously. So this is the clinical tachycardia. And in just a few seconds, this happened. Okay, so what we can see here is a spontaneous conversion from broad complex to narrow complex. The left bundle branch block morphology is now gone. And this is what the intracardiac signals look like during the transition. What we can see here is, obviously, left bundle branch block disappears into narrow. However, the CS atrial activation remains the same with similar HVA activation sequence. Of interest, the VA time of the wide complex tachycardia is 142 milliseconds, and the VA time of the narrow complex tachycardia is 92. In other words, the VA time is longer during wide complex as compared to during narrow. Now, despite having a longer VA time during wide complex tachycardia, we see that the tachycardia cycle length of the broad complex tachycardia is in fact shorter than the narrow complex tachycardia. In other words, the wide complex tachycardia is faster than the narrow complex tachycardia, despite having a longer VA time. So in summary, what we have here is a regular wide complex tachycardia with left bundle branch block morphology, which is induced by atrial incremental pacing. It has a eccentric atrial activation with a 1-to-1 VA relationship and a VA time of 142 milliseconds. This tachycardia then spontaneously converts to regular, complex, narrow complex tachycardia with similar eccentric atrial activation and VA relationship. However, it has a shorter VA time and a slower ventricular rate. So what are the possibilities of these findings? Could this be Kuhlman's phenomenon? So just a recap of what Kuhlman's phenomenon is. It is defined as a prolongation of the cycle length of an orthodromic reciprocating tachycardia, ORT, during bundle branch block that is ipsilateral to the accessory pathway. Now, this is a very nice schematic diagram that represents what Kuhlman's phenomenon is. In this case, the patient has a left lateral accessory pathway, and when AVRT is established, functional left bundle branch block occurs. And because of this functional left bundle branch block, when the antegrade conduction takes place via the septal, it has to make a detour and activate the right side first, subsequently travels across transseptally to engage the left-sided accessory pathway to establish the circuit. And because of this transseptal time, the broad complex tachycardia, or the one with the left bundle branch block morphology, has a longer tachycardia cycle length. Now, this functional left bundle branch block recovers spontaneously, and when that happens, antegrade conduction down goes directly over the left ventricle and engages the left lateral accessory pathway, therefore removing the transseptal time. And the result of that is that the narrow complex tachycardia is faster. So that is classical Kuhlman's phenomenon. So in our case, this is not classical Kuhlman's phenomenon because in our case, the tachycardia cycle length is faster during bundle branch block, while slower without bundle branch block. Now I bring you back to these intracardiac signals that I did not show in my previous slides. This is the same exact snapshot, but now I would like to just show you an interesting finding in this particular patient. Now we found that between the broad complex tachycardia and the narrow complex tachycardia, there is a difference in the AH and the HA time, in which the AH time of the wide complex tachycardia is shorter than the AH interval of the narrow complex tachycardia, while the AH time of the wide complex tachycardia is longer compared to the HA time of the narrow complex tachycardia. Now, it's easy to explain why the HA interval is different between the broad and the narrow complex. As I mentioned previously, in the case of Kuhlman's phenomenon, because of the functional left bundle branch block, it takes a longer time for the conduction to return from ventricles to the atrium. Therefore, wide complex would have a longer HA time compared to narrow. So this can be explained. But what then accounts for the difference in the AH interval between the broad and the narrow complex? So that is the question. So what we have here is called paradoxical Kuhlman's phenomenon. That's the diagnosis of this patient. It is defined as the paradoxical shortening of the cycle length of an ORT during functional bundle branch block that is ipsilateral to the accessory pathway. This is a very nice animation that I took off from YouTube. I'll leave the link right at the end of the presentation, but I'll just like to leave this video on for like 5 seconds for the audience to appreciate. Right? So for paradoxical Kummel's phenomenon to occur, there needs to be three necessary conditions that is pre-existing in that particular patient. Number one, there needs to be dual avinodal physiology. And two, the refractory period of the antegrade avinodal fast pathway should be longer than the conduction time of the HA through the ipsilateral bundle branch and the retrograde accessory pathway. Number three, the refractory period of the antegrade AV nodal fast pathway should be shorter than the conduction time of the HA with the bundle branch block ipsilateral to the accessory pathway. Now, this all seems quite technical, a lot of words, and can be potentially confusing. But I would like to offer a simple explanation in the context of my patient. So, paradoxical Kummel's phenomenon is essentially an interplay between HA and AH interval during the tachycardia. So in our case, our patient has a left lateral accessory pathway. Orthodromic AVRT is triggered during atrial incremental pacing, and the orthodromic AVRT starts off with a functional left bundle branch block. Now, as you know, and as we have mentioned in the past few slides, the functional left bundle branch block causes a longer HA time. So longer HA time means that the time taken for the impulse to conduct retrogradely from V to A and subsequently to the AV node, this time is prolonged during functional left bundle branch block. And it is this prolonged in the patient with dual AV nodal physiology, this prolonged HA time allows the AV nodal fast pathway to recover from its refractory period and to take part in the sustenance of the orthodromic AVRT and be the antegrade limb of the AVRT. And as we know, when the conduction of the AVRT goes down the fast pathway, the tachycardia is generally faster. In this patient, the functional left bundle branch block then spontaneously recovers, and the recovery of the functional left bundle branch block results in a shorter HA time. That is to say that the time it takes from V to conduct back to A and to the AV node, this time is shortened when functional bundle branch block disappears. So this earlier return in retrograde signals is met with the fast pathway that is still in refractory. And the result of that is preferential conduction down the slow pathway. That is to say that from fast pathway, switch to slow pathway, and now the slow pathway becomes the antegrade limb of the AVRT. And the result of that is a slower tachycardia overall. Okay, so this change from fast to slow pathway accounts for the change in AH interval from narrow to broad. Therefore, in broad complex tachycardia, the cycle length is shorter, and in narrow complex tachycardia, the cycle length is longer. Therefore, paradoxical Kummel's, right? So at this juncture, some might start to ask me, well, in functional left bundle branch block, the HA is longer and the AH is shorter. But wouldn't the longer HA counter the effects of the shortened AH? Well, that is a good thought, but in paradoxical Kummel's phenomenon, is all about which one predominates. Is it the AH predominates or the HA predominates? Now, in this case, in paradoxical Kummel's, AH is the one that predominates in the sense that if the reduction of or if the shortening of the AH interval is shorter than the lengthening of the HA interval, then the overall effect will be a shortening of tachycardia cycle length. In other words, a faster tachycardia. And the opposite is true for narrow complex. So anyway, the ablation was pretty much straightforward. The accessory pathway was found at the lateral mitral annulus, where the fuse signal was found in distal CS, and we ablated right at the lateral mitral annulus, where the earliest A was found during V pacing, and we achieved acute success in the ablation. So final diagnosis, orthodromic AVRT, using a concealed left-sided accessory pathway with paradoxical Kuhlmann's phenomenon. With that, thank you for your attention.
Thank you for that excellent presentation, Dr. Koo.
Thank you.
And before we starting the discussion, I have one question. Could you show us the slide just after the paradoxical Kuhlmann's law?
Sure.
Yeah.
Is it this one?
This one, right? And I think the first QLS still white QLS with bundle branch block, same degree of the bundle branch block, right? But I felt the AH interval just after the false QLS complex prolonged at this time, right?
I'm sorry, Dr. Kim, do you mean the AH interval prolonged
Prolonged, yeah, at the time, right?
at this time, the AH
No.
interval?
Yeah, just before.
Just before here, you mean?
Yeah, right. AH. What made
Yes,
the
yes, yeah.
AH
It does.
prolongation? Still
Yeah.
there is bundle branch block.
You mean this interval?
No, AH.
Here?
Yeah.
Yes, it does look prolonged.
What made the? I'm curious about what which factor or what contributes to that prolongation of the AH interval at that beat, because the previous QLS is still bundle branch block.
I think this is spontaneous.
It's just my curiosity. Because AH was consistently short, relatively short under the bundle branch block, but just after the last bundle branch block pattern, AH suddenly prolonged. And
I didn't measure the HA interval in this particular segment. I'm not sure if this is the same as this.
Is it, can I ask you why?
Yes,
It
please.
is you're measuring within the transitional period of the left bundle branch block to the becoming narrow complex.
Yes.
Look at the septal ventricular EGM. They're not stable. Can you see that? Septal ventricular EGM, those four complexes, wide ones, they're all different. His bundle EGM, ventricle. So you got HV, VEGM. Take a look at the V. That VEGM, next one. They're all different. And then when you become narrow complex, also different. Can you see that?
Yes.
For the narrow complex. What is the explanation for this? So a patient had a progressive fusion going on here. And it's difficult to tell because you don't show us RV EGM. And a right ventricular EGM would tell you that your slide don't have a right ventricular EGM. It's hard to prove it. So that may explain why you have a wobbling fluctuation of the AH interval. Okay. So question we have here is there was a left bundle aberrancy terminated abruptly or it terminated gradually? If you have left bundle,
Green channel looks like RV.
which one?
Green top.
Yeah, on top is RV, that's RV?
I think so.
Yeah, so if you look at the, then you look at the RV EGM then. If you look at the, unfortunately, that letter is covering RV. Do you see it? Initial Q of RV. They're changing. Can you see that? Initial, very
Yes,
40 millisecond Q.
This one.
Yes, and then next one to the narrow complex. Keep changing. You see that?
Yep.
So because the subtle activation occur early, transsubtle activation during the QRS complex, you really want to look at the right ventricular EGM first 40 milliseconds, okay?
Yes.
And also it's important to show, to establish paradoxical Kummel phenomenon, as far as I know, you need to measure the AH interval when tachycardia is stable, not during the transition. So I suggest you go back to the tachycardia when the sustain relatively stable. If they have a tracing, we should measure that. Then yeah, there you go, right here. So even here, if you look at your now PEGM is fairly stable. Measure here, see whether tachycardia cycle length is truly shorter or longer. That would give you answer, because you got nice His bundle potential, and then you got a stable B. So you got AHV EGM stable. So
Yes.
compare this to the narrow complex one stabilized afterward conversion. That would be the fair answer, cell comparison. That may answer why Dr. Kim asking that question. Okay?
Okay.
Yeah.
Thank you.
Thank you, Dr. Wang. And Dr. Kirelma, could you please start the discussion?
Good morning, everyone. My name is Kirshma. I am working in AP doctor in Third State Central Hospital. So first of all, thank you for Dr. Kenneth Koo. It's a really interesting case, especially the junior AP doctors, because there is always a bundle branch block morphology with the tachycardia. This kind of transition, most common way is the Kummel sign. We always check the Kummel sign, but not that kind. I think we are not generally use this paradoxical Kummel sign. So that's me. This is the interesting case for me. So professors tell us more, tell about the paradoxical Kummel signs, because we already know it's all left lateral accessory pathway, so it's easy to ablate, but we need to sure about, is it exact, we need to ablate this point or not. So that's the point. So I think Dr. Fan, can you explain, do you have any other trick about this kind of ECG? What should we do more?
Okay. We all need to go through the classical PVC maneuvering. The bundle branch block and during the aberrancy is basically they're using mechanism of refractory variation. So if you deliver S2 from the ventricle, and you can probably make it even wider to the narrow to the wide in this type of patients. Now, Dr. Kim mentioned earlier that one of the bit during the transition, there was a PR got longer. And that is a way to clue that you have a slow pathway jump probably. But it is important also, you mentioned now, the baseline study, you want to look at there's a dual the physiology, antegrade retrograde conduction. The presenter told us that the VA conduction was not present during the B pacing, but he did not say whether the antegrade conduction of slow pathway was present or not during the A pacing. So I think you knowing that in upfront will help you understand this much better, okay? So we did not have that information, so I wonder whether they did A pacing, CS pacing to look at whether do I have another physiology baseline in this patient. Is not also, rule out that if you had, let's say, patient as an AVNRT with the AVRT bystander, this maneuver is going to be very important. Yeah, so you have to do S2 from A and B to make sure that slow pathway activation is not a bystander, it's a passive, it's active. So then you have to really discuss whether you want to eliminate the pathway first or you want to eliminate the AVNRT first, okay? So this is those type of maneuvering. It's not just for the Kummel cases. Every case is important. That's why you need to have a good His bundle catheter, CS catheter, RV catheter, and the atrial catheter. Now, there's a catch here. You don't want to put RV catheter close the septum, right bundle. You got to move away so that you can truly differentiate these two. Sometimes when you put the catheter to the septum, you're favoring nodal conduction through the septum because conduction to get right bundle faster than transept activation to the left side. That can sometimes create a trouble. So I suggest you put a different site and RV, LD, or vice versa. And there's a paper written by Mel Tryman the last couple of years, emphasizing importance of pacing, base versus apex, so association with SBT. That can answer your question about this phenomenon. Okay. So I suggest you all, everybody read that. It's a very, very important paper. Very simple thing, but very valuable in my EP lab. Did that answer the question?
Yes, thank you for your great experience, the sharing the great knowledge. Can you tell us the septal apical septal, the last sorry.
You mean so if you pace a base.
Yeah. Just
it take a longer time to conduct through the right ventricle and eventually invade the septum and turn around, come back up to the septal. Compared to when you pace the apex, you're closer to the right bundle, so then your time of activation is going to be different. Obviously, if you pace away from the location of axillary pathway, similarly take a longer time to invade. So you're able to demonstrate that longer difference timing between the septal versus base. Okay, so you'll have a less fusion. Let's put that way. So that's the reason that when you have a left side pathway, we just don't pace the RV many times. You wanna do the pacing or LB pacing. Simplest way to do that is before you ablate, you gotta do transeptal in this case probably, or transaortic, whichever you do. Before you ablate, before you map, put the catheter, a mapping catheter, beyond the way you think that pathway is, pace, so that it reverses the propagation of the ventricular activation, and you're able to evidence much better your pathway and also the Kummel phenomenon and many other things. So in left side case, probably you want to do RV, maybe free wall or either outflow tract versus LD beyond the pathway anterior wall pacing. So take a look at that. Would be much more evident than RV base or apex. Okay. But yeah, right side pathway, you want to do base and apex. Okay. That would be the maneuvering we do.
Okay, thank you, Professor Fan. Would you like, Dr. Park, would you like to give more information or additional information in this kind of case?
You guys think Dr. Park? Yeah, right.
Yeah.
This Sinam Park, Korea. Oh, how did you know? I'm attending the conference. Thank you for inviting me. And I enjoyed Dr. Ku's presentation very much. It was very interesting case, and honestly, it was first time to me to see that this kind of typical paradoxical Kummel's role, and still I have some curiosity why there is the anterior conduction, avenal conduction was all of a sudden changed to fast passage conduction to slow passage conduction, as Dr. Deonkin mentioned. But if the two different avenal conduction pathway, their ERP is similar, it could be, but I never seen that so far. In my experience during the ABRT study, if there's a Kummel's role does match to the local electrogram finding, I always think about the potential, the two different tachycardia. For example, the ABRT and ADNRT plus the left lateral accessory pathway as standard, or we should think about the potential multiple accessory pathway, including right side bypass tract. So after ablating the left lateral pathway, I hope you did all the EP study again to try to induce AV node reentry or any other multiple bypass tract. That is my experience.
Thank you for Dr. Kaneko, could after the ablation, could you check? Did you check the EP study again? And is there any sign of the another accessory pathway or dual AB nodal physiology?
Yeah, sure. So, full disclosure, when we did this case, because the tachycardia was induced quite fast, so we studied it and we come to a conclusion that this is AVRT. So we ablated it and with success. But then after the ablation, before the patient came out, we then studied the EGM and we found this paradoxical finding. So we did repeat the EP study to see if we can induce any other tachycardia, and we did not induce any other tachycardia. However, I did not show this slide because of the time limit, but since you asked, I would like to just show this. Okay, I'll just share my slides again. Right. So this is post ablation. We repeated the EP study, but of course, it wasn't the full 3 catheter study. We tried to induce it via atrial incremental pacing, extra stimulus pacing, sorry. And this is what we saw. It's not a His bundle catheter, granted, but when we reduce the S2 coupling interval, right here we saw a sudden AV jump, not an AH jump, but an AV jump. And we suspect that this is evidence of the presence of a slow pathway. Now, we did not proceed to ablate the slow pathway because despite aggressive pacing and with isoprenaline, no tachycardia could be induced from here.
Thank you. Is there any other person ask some question about this kind of case, these cases?
I think it's important to remember that the Kumel's phenomenon or either dual AB nodal physiology is a electrophysiological property of the functional tissue. Does not mean you have to ablate slope at any of those steps, but for you to have a paradoxical Kumel experience, you clearly should have a dual AB nodal physiology. Without it, very difficult. Like said, Dr. Park said, I forgot to mention one pathway. If you have a decremental conducting pathway, you could have a Kumel's phenomenon, paradoxical Kumel phenomenon, but that's very rare because the decremental conducting pathway usually does not manifest this way anyhow. So I think it's just a matter of electrophysiological phenomenon. It's very interesting to everybody to understand. I think it's very important. So physiology, electrophysiology is a more fascinating actually ablation in my standpoint. And I always enjoy looking at the EGMs as well. So pay attention to the His bundle EGM. His bundle EGM, I always remind you, is not just about His bundle potential. You get to look at the atrial ventricle at the same time. So His is a very rich electrogram that you should really appreciate very much. So I will insist to all young fellows put a good His bundle potential through the entire procedure. Pay attention to the change in His bundle V and His bundle A. That give you answer many times in your diagnosis. Okay?
Yes. Thank you.
Thank you.
Thank you, everyone. Wonderful job.
Okay.
Enjoy the case.
Thank you
Okay,
so
please
much.
know.
It's a
Thank
very
you.
interesting, wonderful case. Thank you.
Okay, we look forward to seeing you our next conference. Thank you, everyone. Thank you.
Thank you for everyone. Have a good day.
Bye.